Hi everyone, welcome to MedGoto. Today we're going to be talking about hypercapnia. In other words, hypercapnic respiratory failure. If you have not watched our previous video on respiratory failure, I will strongly encourage you to spend some time to watch those videos so that you can have a very good background to what we're going to be discussing today. So before we go and talk about hypercapnic respiratory failure, there are a couple definition or some physiology or some formula that I want us to go over before we talk about the causes of hypercapnic respiratory failure. The first one is minute ventilation. So when we look at the ventilation rates, by definition, ventilation rate is the volume of air that moves into and out of the lungs per unit time. So that will be our ventilation rate, right? And then when we use the word, the formula that we use for minute ventilation, which is represented by VE. So whenever you see me writing VE, it means minute ventilation. So minute ventilation is going to be our tidal volume multiplied by the respiratory rate, right? So the VT there will be our tidal volume. And of course, RR will be the respiratory rate. So that will be our minute ventilation. So I'm going to just draw this just to have like a graph, like a visual representation of what I'm trying to explain. So if we look at our respiratory tree, right? The respiratory tree is divided into two, right? So we have the conducting zone, and then we also have the respiratory zone. So for the case of this conversation, so I will use this area to represent our conducting zone, right? And then this area is going to be our respiratory zone. So normally the gas or the air in the conducting zone, they do not participate in gas exchange. So all those gas in the conducting zone, they don't participate in gaseous exchange, right? So, but the air in the respiratory zone, those gas in the respiratory zone, they participate in, they take part in gaseous exchange, right? So let's assume that this is our alveolar, right? So if we want to calculate the alveolar ventilation, so if you want to look particularly at alveolar ventilation, right? So to look at alveolar ventilation, which is represented by VA, right? So that means we need to remove the dead space from the tidal volume, because remember the whole gas that move in and out of the lungs, of the whole lungs, with each breath, right, is our tidal volume. And then out of all the tidal volume, it's not all of them that is going to involve in gas exchange, right? So the dead space does not involve in gas exchange, right? So we have to remove that from this tidal volume. So the tidal volume minus VD, which is dead space, multiplied by the respiratory rate. So that will give us the alveolar ventilation. So alveolar ventilation is going to be equal to tidal volume minus dead space multiplied by respiratory rate. So that will be our alveolar ventilation. Right? So having said that, let's move on to the next formula that I also want us to talk about, right? So when we talk about hypercapnia, right? So when we talk about hypercapnia, right? By definition, it means that there is elevated PaCO2, which is partial pressure of carbon dioxide in the arterial system or in the blood, right? Is elevated. So that's what we mean by hypercapnia. So, and usually the cutoff that we normally use is anything more than 45 milliliter mercury. So if it's more than 45 milliliter mercury, by definition, that's hypercapnia. And of course, anytime there is increase in partial pressure of carbon dioxide, that normally decrease our pH, right? So elevated partial pressure of carbon dioxide will also lead to decrease in pH. So in this case, the pH will be less than 7.35. So that will be the definition of our hypercapnic respiratory failure. So hypercapnic respiratory failure, so elevated PaCO2, right, more than 45 with pH less than 7.35, right? So that would be hypercapnia. So when we look at this formula, right? So before we go to talk about that formula or talk about the causes of hypercapnia, so there are different. When you look at hypercapnia, hypercapnia could be acute, right? So patient who have acute hypercapnic respiratory failure, right? It could be chronic, right? So, or it could be acute or chronic, right? So most of the time, with acute, these are patients that they do not have any baseline CO2 retention. So they don't, so no baseline CO2 retention. Whereby chronic, our patient who already have a baseline, they have CO2 retention. So chronic CO2 retention. Whereby acute and chronic, these are people that already have CO2 retention, and now because of some acute condition, right, they're also having additional acute retention of CO2, right? And then sometimes it might be difficult to be able to know, are we dealing with acute, chronic, or acute and chronic? One of the ways that, one of the things that I normally look at to be able to differentiate if this is acute or chronic or acute and chronic, right? Normally, the normal PaCO2 is usually 40, right? So that we normally use cutoff, and then bicarb, right, is usually 24, right? So if I have a patient, right, that comes in, we did ABG on the patient, and on the ABG, right, let's just assume that the PaCO2 on this ABG is, let's just give it a value, let's say 55, right? So by definition, this is hypercapnia, right? Hypercapnic respiratory failure based on our definition, right? So the next question I want to ask myself, right? And like you mentioned, right, elevated PaCO2 will lead to respiratory acidosis. So this patient will develop respiratory acidosis, right? And for respiratory acidosis, the compensation for respiratory acidosis would be metabolic alkalosis, right? And metabolic alkalosis basically means that they are retaining bicarb, right? So I expect the bicarb to be elevated, right, if there's compensation. So where I'm going with this is that normally for acute respiratory acidosis, right, the metabolic compensation is usually very slow. So you don't see the compensation right away. But with chronic, we expect to see compensation. So metabolic compensation for respiratory acidosis is usually very slow, right? So you may not see it in the acute setting, But in chronic, I expect to see some compensation, right? So in this patient, right, that the PaCO2 is 55, right, which is respiratory acidosis. So what is the expected compensation that I'm looking for in this patient? What should the bicarbonate be, right? So normally for every 10 milli, for every 10 millimeter mercury increase in your CO2, right, above normal, right, and above normal, and the normal is 40, like we mentioned, right, above 40, right, the bicarb should increase by approximately 4, right? So what do I mean by that is that, so when we look at this patient, right? So this patient bicarb is 55, right? So what's the expected, this patient PaCO2 is 55. So what's the expected bicarb I'm looking for in this patient, right? So in this patient, so from 40 to 50, that would be 4, right? And then from 50 to 55, maybe additional 2. So that would be 4 plus 2. So that would be 6. So 6 plus 24 gives us 30. So the expected bicarb that I'm expecting in this patient, right, the expected compensation should be bicarb of 30, right? It should be bicarb of 30. So if I look at the bicarb of this patient, if the bicarb is 24, right, I'm expected to see 30, but now this patient has 24, right? So this will tell me that most likely this is acute hypercapnic respiratory failure because there was no compensation, right? If I look at the bicarb, and the bicarb is the same thing as what I'm expecting, so it's expected compensation, right? So I know most likely it's probably chronic, right? So if it's 30, right, so most likely I know it's chronic. The patient has been living with it for a while, right? So if I look at the bicarb, and the bicarb is like maybe in between, let's say like 28, right? So it's not 24, it's not 30, right? So it's kind of like in between, right? So this could be acute on chronic hypercapnic respiratory failure. So they already compensated for the chronic one, but they are yet to compensate for the acute event that just occurred. So that would be acute on chronic hypercapnic respiratory failure. So no compensation, likely acute, right? Compensated, right? Appropriate compensation, maybe chronic, right? And in between, right? Like not, so there's partial compensation. So that could be acute on chronic hypercapnic respiratory failure. And don't forget, you should also bear in mind that we also have to look at the whole patient we have to look at the big picture of the patient, right? Because sometimes most of these patients, they're also on diuretics, right? Example like furosemide, right? And a furosemide can lead to contraction alkalosis, right? So in addition to the compensation, this patient will also have maybe contraction alkalosis on top of it, right? And most of this time, this patient also have like a mixed disorder, right? Respiratory acidosis, metabolic alkalosis, and then most of the time, when you look at the pH, the pH could be normal. Yes. And then one of these days, we're going to do a whole lecture on acid-base disorder. So far we're talking about hypercapnic respiratory failure. So we said it could be acute, chronic, or acute on chronic, right? So having said that, let's move on to the to talk about the causes of hypercapnic respiratory failure. So before we go to the causes, so let's just remind ourselves the formula we spoke about earlier, right? We spoke about the minute ventilation, which is the BE, and that's equal to tidal volume applied by respiratory rate. We also spoke about alveolar ventilation, which is VA, which is equal to tidal volume minus dead space. So we need to remove the dead space, area that is not taking part in gaseous exchange, multiplied by respiratory rate, right? So let's now go to how do we estimate what formula do we use, are we going to use to estimate our partial pressure of carbon dioxide, right? So the formula that we normally use is equal to K, right? Multiplied by our rate of carbon dioxide production, so VCO2. So VCO2 is the rate of CO2 production, and a K is just a constant, which we don't have to worry about. Constant, and then divided by, we want to divide this by our VA, right? And then VA is the alveolar ventilation. So that to be our alveolar ventilation. So basically what we are saying here is that if there's increase in production of carbon dioxide, right, that will increase the carbon dioxide that's present in the blood, right? And if there's a decrease in ventilation, that will also increase the carbon dioxide, right? So before we continue on this formula, so when we look at our VA, like we said that VA, which is the alveolar ventilation, equals our tidal volume minus dead space multiplied by respiratory rate. Also, meaning ventilation equals tidal volume multiplied by respiratory rate, right? And then when we talk about ventilation, we always said ventilation is a word for carbon dioxide, right? So there's an inverse relationship between ventilation and our PaCO2, the carbon dioxide. So if the ventilation is high, that means we're actually blowing out a lot of CO2, right? So the partial pressure of CO2 will be low in the blood. But if the ventilation is low, right, so that means that patient is retaining a lot of CO2. So they are not getting rid of those CO2. So the CO2 in their blood will be high. So increased ventilation, which is what we want to refer to as hyperventilation, right? So that will lead to a decrease in a PaCO2, right? If there is decrease in ventilation, which is going to be hypoventilation, so hypo, which is what we are concerned about with this lecture. So that will lead to increase in a PaCO2. So something that we should just remember, right? So hyperventilation will decrease our partial pressure of carbon dioxide. Hypoventilation will increase the partial pressure of carbon dioxide. So having said that, so let's come back to this formula, right? So PaCO2 equals to our constant multiplied by the rate of carbon dioxide production divided by our alveolar ventilation, right? And the alveolar ventilation, right? So let's relate it to minute ventilation, right? So we know that the alveolar ventilation, right, which is VA, is a portion of the total ventilation, which is VE, right? Our total ventilation or minute ventilation that is not dead space ventilation. Right? So that will be indirect. So the total ventilation, so out of that total ventilation, that portion of it that is not a dead space is going to be our alveolar ventilation. So the other way we can estimate that, so we can say, so what's the portion of that tidal volume that is not dead space? So what's the portion of the tidal volume that is not dead space? So if you want to come up with that portion, so we can say that tidal volume, right, minus dead space divided by tidal volume. So that will give us that portion of that tidal volume there is not dead space. Just like when we are calculating ejection fraction, when you say n diastolic volume, right, minus n systolic volume divided by n diastolic volume. So kind of like a similar principle here. So that will give us that portion of the tidal volume that is going to be taking part in gaseous exchange. In other words, they're going to be in the, we expect it to be in the alveolar, right? Involved in gas exchange. And then we can simplify this equation to 1 minus tidal volume, right? Divided by, dead space divided by tidal volume. So we can simplify, because if we expand this formula further, right? So that will be tidal volume minus dead space. So that gives you back this formula, right? So we can further simplify this to this, right? So the reason I'm saying that is that you're going to see in some textbooks when you are reading them, right? So the partial pressure of carbon dioxide is going to be expressed in a different way, right? So that we don't get confused, right? So like we said earlier, PaCO2 equals to CO2 production divided by dA, right? And then we can, this same formula will also be equal to our K multiplied by V CO2, right? Divided by, remember we mentioned our alveolar ventilation earlier, which is going to be our tidal volume, right? Minus our dead space, right? Multiplied by respiratory rate. And then let me just change this so that we don't get confused, right? So I have to change this one back to the abbreviation that we've been using, which is BT. So that's tidal volume, right? So that would be another way that we can express it, right? And of course, you're going to see some textbook whereby they also express it in a different way. I'm so sorry about that. We're going to be K multiplied by CO2 production divided by, right? So the proportion, like we mentioned, the proportion of that tidal volume, right? There is not part of the dead space, right? And there is not dead space ventilation, right? Which we express as 1 minus VD, which is our dead space divided by tidal volume. So we can multiply this by minute ventilation. So multiplied by 1 minus V, the dead space over it. So you can see this different formula being used in different textbooks, but they are all saying the same thing. And then once you understand this formula, you can come up with the differential diagnosis or the differential that can lead to hypercapnic respiratory failure. So looking at this formula, if a patient has increase in carbon dioxide production, right, like in the case of sepsis, seizure disorder, that can lead to increase in the partial pressure of carbon dioxide. So that can also lead to hypercapnic respiratory failure, right? If a patient has increase in alveolar dead space, right? So if the dead space is increased, right? So there's increase in dead space, that could also lead to, because if this dead space is increased, that means the denominator is going to decrease, right? If you decrease this, by the time you subtract it, your denominator is going to be I, and by the time you divide that denominator by your numerator, that will make your PaCO2 to be high, right? So increase in the alveolar dead space, right? We also increase your PaCO2, right? If your minute ventilation, right? If the ventilation is decreased, maybe because as a result of decreased tidal volume or decreased respiratory rates, that could also lead to increase in the partial pressure of carbon dioxide, right? So just by looking at this formula, I can come up with the causes of hypercapnic respiratory failure. So let's now move on to talk about the etiologies of hypercapnia or hypercapnic respiratory failure. So we're going to be using that formula. So the first one is going to be hypoventilation. Hypoventilation. And like we mentioned earlier, we said our minute ventilation, right, equal to respiratory rate multiplied by tidal volume, which is V2. So if there's a decrease, so under hypoventilation, so it can be due to decrease in respiratory rate. So if the respiratory rate is decreased, and what are the things that can lead to decreased respiratory rates? So it could mean probably there is a decrease in respiratory drive. Respiratory drive, right? Like patients who are on opioid, right? Who are on sedation, right? Those can suppress overdose, opioid overdose. That could suppress the respiratory drive, right? Or CNS injury. It could also be metabolic alkalosis, because with metabolic alkalosis, the compensation for it is respiratory acidosis. And what that means is that patient needs to be retaining CO2, right? And for them to retain CO2, the body will suppress the respiratory rate so that they can retain CO2. So that will also lead to hypoventilation. The third one is neurologic diseases, right? And under this, we divided this into three. So it could maybe structural problem in the brain. Example of structural problem in the brain, if somebody who has a brain tumor, right? Stroke, like someone who has a very massive stroke. So all this will also suppress the respiratory rates. It could also be metabolic or toxic encephalopathy. And then with this example, maybe things like sedation, severe sepsis, but just bear in mind, sepsis itself too will also activate the respiratory center, so patient can have respiratory, they could also have respiratory alkalosis, so something to bear in mind. So if somebody has severe sepsis, that will also suppress the respiratory drive. Also things like hypothyroidism will also do it. And then the last one is going to be infection. If somebody has CNS infection like encephalitis or meningitis, that will also suppress the respiratory drive. So that's decreased respiratory rate. The next one under hypoventilation, right? Remember, we're still looking at the formula for minute ventilation. We talk about decreased respiratory rate, because if you decrease the respiratory rate, that will decrease the minute ventilation. And because minute ventilation is decreased, which is hypoventilation, the PaCO2 will be increased. So the other one is decrease in tidal volume. So if the tidal volume is decreased, so B, decrease tidal volume. So decrease in tidal volume. So basically, patient is not bringing in enough tidal volume, right? Maybe because there's a weakness in their muscle, right? And so on and so forth, right? So let's go through the example. So it could be a neuromuscular disease, right? Neuromuscular disease. And of course, we can divide it again into like three, right? So it could be a problem with the neurons or with the neuro itself, right? The neuro part of it, which could be things like GBS, Guillain-Barré, right? Whereby they are destroying, there's autoimmune destruction of the Schwann cells that mynates the peripheral neurons. So because of that, those patients have ascending paralysis. And that's why the most common cause of death in them is actually respiratory failure. ALS, right? Whereby there's destruction of both the upper motor neuron and the lower motor neuron. And that will also affect the diaphragm, and that will also cause hypoventilation. that can lead to hypoventilation because they can't bring in enough tidal volume. Next one is poliomyelitis, right? It's also another one. Poliomyelitis destroy the anterior arm, which is also called ventral arm, and as a result of that, right, the innervation, the signal cannot pass through to get to the diaphragm, right? And of course, if maybe somebody just had a recent CABG and there's damage to the phrenic nerve, so phrenic nerve injury, because the phrenic nerve is what keeps the diaphragm alive. So that will also lead to hypoventilation. So the next one is going to be the junction between the neuron and the muscle. So we have to call it neuromuscular junction. So at the neuromuscular junction, it could be problem before the synapse, right? So it could be problem before the synapse. So if it's problem before the synapse, that's usually Lambert 18, right? Myasthenic syndrome, which is antibody against the presynaptic calcium channel. So as a result of that, that will lead to decreased release of acetylcholine into the synapse, and that will lead to decreased muscle contraction. So that can also affect the diaphragm. Okay? The other one is myasthenia gravis. So with myasthenia gravis, this is problem with the postsynaptic, whereby they are making antibody against the postsynaptic acetylcholine receptor. So as a result of that, even though we're releasing acetylcholine to the synapse, but it can't bind to the acetylcholine receptor, and that will also lead to decreased signal getting to the diaphragm. So that will also lead to respiratory failure. Right? And then the last part of it is problem with the muscle itself. So if the problem is with the muscle, so things like if there's inflammation of the muscle, like in the case of dermatomyositis, or polymyositis, right? This could also lead to muscle weakness, so that will cause hypoventilation. It could be muscular dystrophy. So muscular dystrophy, right? Like in the case of maybe Duchenne muscular dystrophy. It could be maybe problem with the diaphragm, right? Someone who have maybe from the condition, right? Problem with the diaphragm, whereby the diaphragm is not working very well. And of course, it could be maybe because they are not making enough ATP to be able to allow the muscle to work very well, like in the case of hypophosphatemia. So if somebody have low phosphate, you can make ATP. And then at least two group of patients that we should always watch out for, like a patient with refeeding syndrome. When you start, patient who have severe malnutrition, and then when you start feeding them, they start to develop the phosphate is being moved into the cell, right? To be able to trap the glucose inside the cell, and that could lead to hypophosphatemia. Also, patients who have diabetic ketoacidosis, right? When you put them on insulin drip, right? So that insulin move the glucose into the cell, and then the potassium, the phosphate is going to be used to trap, to phosphorylate those glucose and trap them inside the cell, and that will also lead to hypophosphatemia, and that can present with respiratory failure. Right? The other thing under decrease that will also affect the tidal volume, right? So under decreased tidal volume, we mentioned neuromuscular diseases, right? The second thing under decreased tidal volume that will also cause decreased tidal volume is chest wall disease, right? Or chest wall pathology, or you can say extrathoracic, right? Under extrathoracic would be obesity, right? So we have something called obesity hypoventilation syndrome, right? So that's also fall under hypoventilation, right? Because that can prevent them, right, from bringing in enough tidal volume, and as a result of that, they can have hypoventilation and retain a lot of carbon dioxide. The other one is also kyphosis or scoliosis, right? So someone who have a very bad scoliosis, that will also decrease the expansion of the lungs, so they can't bring in enough tidal volume, right? And that could lead to hypoventilation. And the third one is problem with the pleura, right? So if the pleura is also, if there's a problem with the pleura, there might be not enough space for the lung to be able to expand. And as a result of that, that could limit the amount of tidal volume that is coming in, and that can decrease ventilation, right? So example like fibro, if there's a thickening, right? So thickening of the pleura, maybe somebody who have like maybe extensive mesothelioma, or if somebody have like a pleural effusion. So that will limit the expansion of the lung. So we just finished, we just talked about the first, our first cause of hypercapnic respiratory failure, which is hypoventilation, meaning that our ventilation is low, maybe as a result of decreased respiratory rate or decrease in tidal volume, right? So the other one, this next one we're going to talk about is increased dead space, right? So if the dead space is increased, right, that will also increase the partial pressure of carbon dioxide. So increase dead space. That will be our number 2 group of course. So increase dead space. So increased dead space, right, could be due to maybe because of lung Hypercapnia disease, right? Like in the case of emphysema, because if in emphysema, right, there is decrease in the surface area, and because the surface area is decreased, so that means there has to be some area in the lungs whereby, or in the alveolar, whereby the gas there, they are not taking part in gaseous exchange, right? Also CHF, right? So if there's a thickening of alveolar in some area because of the filling of the alveolar with those excess transudative fluid, right? That will also lead to increase in dead space in those areas. And of course, same thing, pneumonia, that will also lead to the similar reason, right? Those alveolar, they are filled with inflammatory cells, right? And as a result of that, there also be decrease in diffusion in that area, so the gaseous exchange there is going to be affected, and those gas in that area, right, they want to be dead space, right, basically. And the last one we can also add there is interstitial lung disease, right, whereby there's fibrosis, and as a result of that, the alveolar wall is very thick, right, and that can lead to decrease in diffusion. So those affected area in the alveolar, right, they want to be decrease in diffusion in that area. So that means the air in those areas, they want to be even like what, like a dead space, right? So if this is our alveolar, and then we have our blood that's coming in. So if the alveolar, right, is filled with maybe inflammatory cell, like in the case of pneumonia, or is filled with transudative fluid, like in the case of CHF, or there's thickening of the alveolar wall, right? So all this, so that means all those air in this area, all those gas in this area, they are basically going to be what? Behaving like a dead space because they are not taking part in gaseous exchange. The next one under that can increase our dead space is going to be airway disease, right? So, like we think of all those obstructive airway, all those things that can cause obstructive airway, right? Like in the case of asthma, COPD, or obstructive sleep apnea, bronchitis. So any of these, right? Because we call them obstructive airway, so meaning that on expiration, during expiration, there's premature closure of the airway, right? Because of the increase in dynamic force, right? So those airway and a reduction in the radial traction, right? During expiration, so there's premature closure of the airway. So as a result of that, those patients, they are retaining a lot of carbon dioxide, right? And of course, because they are retaining a lot of carbon dioxide, there are a lot of trapped air in the lungs. So of course, those gas will not be participating in gaseous system, right? So as a result of that, they want to be retaining a lot of carbon dioxide. So that would be another cause of hypercapnic respiratory failure. So first one we mentioned hypoventilation. Second one we mentioned increase in dead space. And the last one that we're going to mention, the increase in carbon dioxide production. So increased rate of carbon dioxide production. Classically seen in hypermetabolism state. Right? An example of hypermetabolism states, like case of fever, right? Seizure disorder, sepsis, hyper alimentation. So any of these, right, will increase our body metabolism, right? And that can increase carbon dioxide production. And even you can even add pyrotoxicosis here, right? So, and that can increase our carbon dioxide production. And as a result of that, that can increase the partial pressure of carbon dioxide. So these are the major causes of hypercapnic respiratory failure. Like I mentioned, always good to go with the. I always love to like learn with maybe formula or with a particular story. So in that way, it's easier for me to remember, so I don't forget, right? So in summary, right? So hypercapnic respiratory failure by definition, PaCO2 more than 45. Or pH less and then pH will be less than 7.35, right? Because anytime we have increased PaCO2, that will decrease the pH, right? And after we said that, we have to determine, is it acute hypercapnic respiratory failure, is it chronic, or is it acute on chronic? And based on the compensation, right? If there is no compensation at all, most likely it's acute, right? If there is partial compensation, it could be acute on chronic. And if there's expected compensation, it could be probably is chronic, right? And after that, we'll talk about knowing the formula for minute ventilation, right? And so minute ventilation is equal to our tidal volume multiplied by the respiratory rate. And we also mentioned alveolar ventilation, whereby we have to remove the dead space, which are the areas that don't take part in gaseous exchange, which is going to be tidal volume multiplied by minus dead space multiplied by respiratory rate, and that will give us the alveolar ventilation. And then from there, we now come down to the formula that we use to estimate what our partial pressure of carbon dioxide should be, which is equal to K multiplied by carbon dioxide production divided by alveolar ventilation. So that the alveolar ventilation will further be equal to our tidal volume minus dead space multiplied by respiratory rate, right? So that's one formula that we can use for our alveolar ventilation. And the other formula we can also use to estimate our alveolar ventilation is estimating what should our estimated tidal volume, out of those tidal volume, how much of it is getting to the alveolar that's actually taking part in gaseous system. And we can estimate that proportion by using tidal volume minus dead space divided by tidal volume, which we can simplify to 1 minus dead space divided by tidal volume. And you can multiply that by the total ventilation, and that will give you what the alveolar ventilation is supposed to be, right? And then once you come up with this formula, then we can easily identify what the etiology of hypercapnic respiratory failure can be. And we said that number one could be metabolism state, right? Like in the case of sepsis, seizure, pyrotoxicosis, and so on. Or we also mentioned that it could be maybe probably as a result of decrease in ventilation, like hypoventilation, maybe because the respiratory rate is decreased, or maybe because the tidal volume is decreased, right? And then we gave an example of each of them, right? And the last thing we mentioned, we said that it could be maybe as a result of increase in dead space, because if the dead space is increased, that will decrease this denominator. And if this denominator is decreased, of course, at the end of the day, the whole formula, the partial pressure of carbon dioxide is going to increase. And that will also lead to hypercapnic respiratory failure. So in summary, one thing I've realized about most of, which is one of the reasons why I really love pulmonary, is that when you look at most of these diseases, right? You cannot, for instance, let's take like COPD. For example, you cannot put COPD. When you look at the causes of hypercapnic respiratory failure in COPD, I can't say that the cause of hypercapnic respiratory failure in COPD is only because of decrease in dead space, right? You have to look at your patient physiology and see what they are doing, right? I can't say it's because of decrease in dead space or maybe because of the airway, because of the bronchospasm leading to decrease in dead space or reduction in the radial traction, leading to premature closure of the airway, leading to increase in dead space, leading to increase in dead space, right? At the same time, it could also be explained by they could also have hypoventilation, right? Also making them to be retaining, that will also make them to be retaining CO2, so they can be retaining CO2 as a result of that. So if the issue is because of airway, right? Maybe they're having bronchospasm, right? The reason premature closure of the airway, right? I can easily fix this by giving them things like bronchodilator, right? And at the same time, I can give them like steroids to decrease the inflammation in their lungs, right? And of course, if I assess them, I see that it looks like there is more issue with ventilation, patient is hypoventilating, then they might probably benefit from non-invasive way of ventilation. So like maybe like example like bi-level, right? So the reason I'm saying this is that respiratory physiology is just so interesting that easily, if one actually understands, because I'm still learning a lot, it's still so much information to learn, you can actually be able to better care for your patient very well. And I hope this help you guys. I'm going to also be uploading more respiratory physiology and pathology in the subsequent video. And we also started our USMLE series already. And I want to encourage us, if you have not subscribed to this channel, don't forget to subscribe and put on the notification bell so that each time we upload a video, we can always get the notification. Thank you for watching.